Hello, everyone. Thank you for being here today. My name is Deja Ivy, and I will be helping moderate today's session on disparities in kidney disease and eGFR with Dr. Crystal Gadegbeku. It is my honor to introduce our speaker today. Crystal Gadegbeku, MD, is chair of the Department of Kidney Medicine in the Glimmick Urological and Kidney Institute of the Cleveland Clinic Health System. She has been involved in the NIH-funded clinical and translational research ranging from epidemiological studies to clinical trials in kidney disease and hypertension, including serving in leadership roles in multi-centered research collaborations. She also has an interest in exploring research engagement of diverse populations, especially among racial and ethnic groups overburdened with kidney disease. Her areas of clinical interest include management of hypertension and cardiovascular disease in patients with chronic kidney disease. Dr. Gadegbeku has served 2 terms as the chair of the American Society of Nephrology, ASN, on both the policy and advocacy committees, and serves as an ASN counselor and the member of the National Kidney Foundation American Society of Nephrology Task Force on reassessing the inclusion of race and diagnosis of kidney disease. Dr. Gadegbeku will be taking questions at the end of the session, so please feel free to type your questions in the Q&A chat in your Zoom toolbar anytime. We should have plenty of time to answer them at the end. With that, I will turn it over to you, Dr. Gadegbeku. Thank you so much for being here today.
Hi, it's such a pleasure to be here virtually with all of you, and I'm happy to be presenting on this topic. Let me share my screen here. Hopefully everyone can see the topic today that I will be discussing is kidney health disparities, and it's an appropriate time to discuss the new eGFR and how that interfaces with how we're take care of patients, and we'll be taking care of patients in the now and in the future. So kidney health disparities with regard to end-stage renal disease, it's pretty well known that people of color are heavily burdened with end-stage renal disease. This is the number per population, per million persons with end-stage renal disease who are Black or of African descent, as opposed to white Americans who have the lowest per population rates of kidney disease, with Hispanics and Asians, Native Americans being higher as well. The reasons for this are thought to be complex and multifactorial and not well understood. And this slide just highlights that. There I was showing you end-stage renal disease. This is the prevalence or the rates of chronic kidney disease when looking at white, Black, and Hispanic populations. And although it is higher in Black individuals, the percentage is not nearly as dramatic as with end-stage renal disease, and averaging around 15% versus 13% for whites, and really very stable throughout the years. And it is even more obvious with Hispanic Americans, where it even seems to be less for chronic kidney disease, but yet so much higher for end-stage renal disease. So why is that? One of the things that has been looked at for a while is it that people of color progress faster? And here's a more recent study that looked at patients who have Medicare Advantage or Medicare Advantage beneficiaries and how they've done over time. Since chronic kidney disease is a long chronic disorder, it takes research that looks over years to actually look at how rates people progress. And this study gives a sense that there is more rapid progression in people of color, with Blacks having, in this line, having a steeper slope, Hispanics having a steeper slope than white populations when you consider loss of kidney function per year. Clearly, as I said before, when we compare to white Americans, Black and Latin Americans are more likely to have end-stage renal failure, and the risk factors are also increased, with Blacks and Hispanics having higher rates of diabetes, and hypertension, and with particularly Black and Hispanic women having a higher rate of obesity, which are risk factors for kidney disease. And on top of that, this is compounded by the fact that these populations tend to be undertreated or undermanaged for chronic diseases overall, and chronic diseases that lead to kidney disease, and also when they have kidney disease. So Black and Latinx Americans are less likely to be insured. If you're not insured, you will not be, your kidney disease will not be detected and optimally managed, less likely to have A1Cs measured, and less likely to actually have care prior to end-stage renal disease. So there are both a number of factors that are interrelated leading to this, and it is a confluence of really maybe some genetic and biological susceptibility, along with social and healthcare access, that leads to this CKD risk, which we're still trying to understand. Let's talk about the genetic and biological. We have discovered that APOL1 risk variants are linked to kidney disease in people of African descent. And this has occurred because of the protection that this APOL1 gene variant has had with African sleeping sickness, which is in sub-Saharan Africa. That has led to a percentage of 13 to 15% of African Americans here in the US having two risk alleles, which seems to be associated with kidney disease. So it's interesting that all you need is one of these gene variants for a protective effect, but that has led to a genetic pressure that people end up having two risk alleles just by survival from African sleeping sickness over time, that there is a significant number of the population that has these two risk alleles. However, not 13 to 15% of people with these two risk alleles do not develop end-stage kidney disease or chronic kidney disease. It's thought to be a two-hit phenomenon. The gene variant creates a susceptibility, but then there's something else that occurs that causes the actual manifestation of end-stage renal disease. One thing it's very clear, when we look at Black people with gene variants, their odds ratio, which is the risk of having end-stage renal disease or disease related to various things like HIV and lupus, et cetera, is astronomically higher, 29 times more likely if you have HIV to have end-stage renal disease with these two risk alleles than if not. And the same thing with lupus, and we're finding that with sickle cell disease and what is considered hypertension attributed disease as well. So obviously this risk variant is important, and we don't understand how the susceptibility occurs and needs to be followed. This just shows progression data, which confirms this. And this is from the chronic renal insufficiency cohort, looking at patients with and without diabetes. However, it doesn't seem to matter. It's that those patients with chronic kidney disease who had the high risk, meaning two risk alleles, had faster progression. The steeper the slope, the greater progression of disease than Black individuals who did not have the two risk alleles, and definitely greater than white individuals. And the pattern is the same with or without diabetes. So what does that mean? Clearly, we have to understand what it is that second hit, along with the genetic parameters. And that is just not it alone, that there's these that there's a biologic reason for the increased rates of kidney disease. And we feel like it's an overlay of social, environmental, and healthcare factors that clearly are playing a role. Number one, poverty is clearly different by race on average, in which Black and Hispanic Americans have more poverty in this country than white Americans by over twofold. And this has been persistent throughout decades. What does that do? Well, with poverty and the economic structure, there is basically many factors that are associated with kidney risk. First of all, the environment may not be as healthy and where people live who live in poverty. Because of that, as well as other issues, the physical environment and the psychological environment there's added stress and what they call allostatic load. Because of that, the reduced ability to gain access to healthcare is playing a role, and therefore the reduced ability to gain medications that are new and thought to be very helpful are important. And then as well, there may be an environment where health behaviors are not optimized in the social environment. And then of course, being educated and insured it plays a role in these things. And as well, just within the healthcare system, there are a number of barriers that are likely to affect the rates of progression of kidney disease, not only, as I previously mentioned, the lack of health insurance and availability of a health provider to take care of patients, but also that there may be a reduced ability for providers to address the needs of the community that leads to optimal care with regard to things like, say, communication and patient-centeredness, particularly when there's these other social and environmental barriers, knowledge and attitudes and ways really to have the most optimal doctor-patient or institution-to-patient relationship. And then there may be things really on the patient side from this environment and social construct, which are barriers to the optimal healthcare. Not only health literacy and health behaviors, but knowledge and ability to self-promote, fear, anxiety, and the lack of trust. So all these things together create a complex system of barriers within the healthcare system, which definitely threaten health equity. And then I'd like to spend a little bit of time talking about the patient awareness aspect, which is obviously something that NephCure and other advocacy organizations are constantly working on. If we go back to earlier data, there has been a considerable understanding that people with kidney disease are not aware that they have kidney disease until very late. And our idea as physicians and healthcare providers is that we can have much more of an impact the earlier we know about kidney disease. This has not changed very much with a more recent study that was done in a diverse population in an urban setting, which showed that still people weren't aware until pretty late in their kidney disease. And one of the reasons why we call it a silent disease is there are not much symptoms, and it really involves an interaction with a healthcare setting to be able to detect early kidney disease. So you can see how the factors that I previously talked about can certainly impact on awareness of kidney disease. Without being aware, there's certainly not much that can be done about it. On the other side of the coin, physician awareness is an important influence on the detection and recognition of chronic kidney disease. And this is a more recent study in the VA hospital setting where insurance barriers are not as much an issue. And it showed that although 94% of patients were screened for eGFR, were detected to have a kidney problem, if you looked at just screening for protein in the urine, which is the earliest sign of kidney disease, that it was much, much less. And that even though there is laboratory evidence of kidney disease, the fact that physicians recognize that by indicating on their billing code that this patient has kidney disease or referred to nephrology was much, much less. And there are several other studies which showed that when physicians actually are as cognizant of kidney disease that they actually mention it on as their billing, that is associated with more optimal therapy. So if we look at UACR at all as by itself, albumin creatinine ratio, that there's a very low recognition of kidney disease. So early detection of kidney disease is very low, even in this population where healthcare access may not have been a big issue. And as I said before, this recognition has been associated with progression. Obviously, if the physician doesn't know about the kidney disease, the care may not be directed as optimally as possible towards treating the kidney disease. This is a trend from this previous study I showed on Medicare beneficiaries that showed that if, and this is rate of decline of kidney function over 5 years, so the larger numbers would indicate faster progression is kind of seen in the steepness of the curve here. But in patients where there was no recognition of kidney disease, there tended to be a more rapid decline of kidney function than in patients who were known to have kidney disease. And notice the GFR is higher here with this patient population. So this is probably indicating patients who had proteinuria that wasn't recognized early, and proteinuria is clearly a factor for faster progression, and indicates early detection is obviously very important. So what about race and eGFR? Because the last several years we've spent time focusing on this this issue, and how does this interplay into this issue of health disparities? Well, as you know, assessing GFR is very important for the detection, screening, and management of kidney disease. And we have used a tool that is relatively inexpensive, creatinine, to look at that. Actually, if we want to measure kidney function extremely accurately or more accurately, the use of substances that are not produced by the body do that very well. However, they're very difficult to use in the clinical setting, requiring hours and hours for determination, and therefore have been limited to research. It is what many of the studies where we use other tools to assess GFR have been based on, or is considered the gold standard. Endogenous markers have been used instead because they're already in the body. We can quickly measure them. They can be done with a blood test. They're not as accurate. We've tried to make them more and more accurate with equations, but the creatinine in itself, as an example, is not very sensitive for detection of early kidney disease, where we want most to understand about kidney function, and that's why the eGFR has become more commonly used. But it was estimated that these are very commonly done tests in the U.S. 280 million serum creatinines per year, so it's an integral part of assessment of kidney health. The problem with the endogenous, or these body markers that come from the body that are used as tools, is they're not perfect. And they can actually, although they help to measure GFR, they can also be measuring other things that have nothing to do with GFR. For creatinine, it's commonly known that differences in muscle mass are going to affect the creatinine level, which will be affecting the GFR equation, but have nothing to do with GFR, age, sex, and it has been thought in the past ethnicity, which has come under lots of questioning. The other marker, the more newly discovered marker, cystatin C, got a whole lot of excitement about this a couple decades ago, particularly for its ability to be used throughout the lifespan of children and adults within the same equation. But as we've used it more and more, we find there are issues with it as well in terms of having non-GFR determinants. And basically, creatinine has kind of won the day. There's now an on-site point of care testing can be done with a simple drop of blood. It's widely available, standardized, and inexpensive. So what is the history of GFR, and how is that related to the populations that have been used to assess the performance of these equations? It's really good to take this into the context of of where we've come to today in 2022. Well, the first equation was the Cockcroft-Gault equation, and in 1976, actually not all that long ago, and it was derived from 249 white men. Yes, there were no women or no people of color involved in that determination of kidney function. It wasn't until 20 years later that the MDRD equation from that research study actually used a gold standard measurement of kidney function and included in the population many more people, including 50% women and a small percentage of Black individuals. There was a race modifier. This is where the race modifier came to be. And because it was only derived out of a small population of Blacks, and it was an equation that had Blacks and non-Blacks, there was the validation or the need to validate this equation. The African American study of kidney disease and hypertension is the largest to this date trial with self-identified African Americans that looked at GFR. And actually used the GFR gold standard equation and looked at creatinine and validated that the race modifier was actually quite accurate in estimating kidney function in Blacks. And so that had been used. And then when the development of the CKD epi equation, which looked at kidney function across the span of kidney health, or GFR, where MDRD focused on patients with kidney disease, this was another validation of the race modifiers use in patients who were Black versus non-Black, and it was a much larger population with slightly more diversity. Certainly not perfect, but actually included Black, Hispanics, Asians, and had a fair percentage of women. Also, much later, the cystatin C equation came about, which has always been raceless, and we'll get back to that. In 2017, the use of race in GFR, it was questioned, and several institutions started to remove the race factor in GFR reporting. It's interesting as we look at creatinine up till this day, looking at populations, creatinine has been known to be higher in self-identified Black Americans than white Americans. And because serum creatinine is the basis of the eGFR measurement, this is how it was derived, that we needed a race modifier to make sure we were accurate about the GFR. So for the same level of kidney function measured in a research fashion, there would be a little bit of a higher creatinine on average in Black individuals. Recent discoveries kind of confirm this, in that there has been some observations that creatinine handling has been slightly different based on race. And there has been a very nice study looking at the extent of African ancestry genes and how serum creatinine increases with increasing African gene ancestry. And further, to take this one step further, this is not just a Black and white issue. It has been noted that in Europe, with the full age spectrum GFR equation, a totally different equation that has been validated in European countries, that across these populations, if you look by country, that the relationship with creatinine is different across these different countries. So the Italian way of relationship of creatinine to GFR allowed for a different adjustment than it did in France, than it does in Spain and other countries. So it's a very interesting phenomenon related to creatinine. Sorry about this. So So there are many unrecognized factors that influence creatinine, and many that need to be further studied. Is there a genetics component? Well, we have seen a little bit of that. Is it environment? Is it the combination of genetics and environment? For instance, where we live, well, how we eat, how that affects creatinine. Are there other factors that we don't know about? Now, in the age of 23andMe and our ability to do genetic testing, we understand that, you know, there's a whole host of possible influences that need to be considered. And the outcry really for the removal of race has a very valid basis. First of all, race is a man-made construct that is not based on biology. It imprecisely measures genetic ancestry. We know this well now that we have the ability to test for our ancestry so easily. And one major factor is race is often assumed in the clinical setting, as opposed to in the research setting where race was self-identified or reported by each individual. So given that the correction of the GFR is incompletely understood, we don't know how to correct for these differences, and we underappreciate when we consider non-Black and Black in an equation the ancestral diversity for which we are derived. This is a major important issue that needs further addressing, which we have done. And we have to understand this under the context of which I previously reviewed for us, that there is an overburden of kidney disease. And so getting this right is very important. So what are the implications of just removing the race modifier, just saying, you know, we shouldn't have it, so let's just take it out of the equation? Well, the problem is that we have all these measurements from Black Americans, self-reported Black Americans from clinical studies, and just removing that would remove their input or their value for determining what GFR should be for a given population, thereby devaluating it and creating a white standard. That probably isn't what we want to do. We want to be able to have an equal, a generalizable, or something that can work in every patient is based on data that is derived from everyone equally. It is interesting that the clinical implications of just removing the race modifier and using the equation for whites as a general equation, just simply by doing that, would increase the number of people with CKD from 15 to 18%. And that actually would change the staging for 30% of individuals who are Black to a lower stage or more severe stage. And what we need to know is that right? Is that appropriate or not? If more accurate, that would be beneficial because it would lead to earlier detection of kidney disease, maybe earlier response to therapies that need to be done to manage kidney disease. But if this is less accurate and is overcalling the amount of kidney disease, falsely diagnosing could lead to false diagnosis, high insurance, worry, and one major issue is underdiagnosing of medications. Consider cancer treatments being under use of cancer treatments because you're basing it on a lower GFR than the patient actually has. So definitely implications of getting it wrong or right. The fact of the matter is that the equations we use, these eGFR, these tools we use, are not perfect, as I mentioned, because they're based on these biomarkers, but also are really an estimate, and that's what the E is all about in GFR. It's an estimate of kidney function that could be 30% higher or lower than what it is. It means your kidney function is around this number. And I know that's hard to conceptualize when you get an exact number of 56 or 41, but it's really an estimate of where your kidney function falls around. And this is a nice example of this, giving us a representation of whether you have a 50-year-old person based on a serum creatinine value who is Black or non-Black, what the difference is, the circles and diamonds in that patient's GFR based on that, but then also showing you that the round part, the estimate, the fact that this is really representing a range and how much overlap there is in that range. And so one thing that is extremely important as a physician is that I convey that this is not an exact number. This is around where your kidney function is, and we have to take that into consideration. So then there was a task force developed, which I was happy to be on, that was sponsored by the National Kidney Foundation, American Society of Nephrology, to really get to the bottom of what we should do about the eGFR equation with the issues that I have already brought to you. And we spent a year deliberating on this topic. It was a very comprehensive review in which phase one, we kind of looked at the problem and the evidence of the problem and the evidence of how GFRs were derived, some of which I've brought to you today, and also thought about race and racism and ancestry, all those things to bring the topic into its proper focus. Then we took all the available equations we thought were worth evaluating, 26 potential equations, to see what would be the best thing to do to be most accurate in all people, and then created recommendations around that. We also had a community input, and we had 2 patient representatives on the task force. The idea of the community output was to get oral and written testimony from many stakeholders, students and trainees who were very involved and very vocal about the issue of race-based algorithms, as well as clinicians, scientists, and health professionals, and most importantly, patients and family members. And in total, we had many great interactions and many individuals providing information mainly from the US, but actually from 3 countries. And so in evaluation of these 26 equations, we of course wanted to look at the ability to have a good measure that was available to all. So important. So national access. So is the assay available? Is it standardized? Is it implementable right away? The other thing is it good for everyone? Has it been tested in as many and diverse populations as we have to come up with a reasonable idea that this is not going to bias any one group or the other? And is it good for clinical management and tracking of disease, for epidemiology and for research? And does it perform well as a measure? So all those things being very important. What we found in our review is that we wanted something that was feasible for national use right away. And there's just no way around it. Creatinine is standardized, it's widely available, it's cheap. Cystatin C, although it's raceless in its equation formation, is not available everywhere. And we needed something that was going to be good for that. The other thing is we wanted something that we could use over time for population assessment. And creatinine is just not to be beat. In terms of diversity, in the equations we looked at, were they looking at diverse populations and how much variation was there in the populations? What we found was that there's very limited information among other ethnic and racial groups. It's been basically a Black, non-Black evaluation. And so much more research is needed to make sure we don't have, we have not created a bias by social groups. And then performance. Obviously, it's very important that a measure or tool that we use is accurate. And there's a lot of things that affect accuracy. There's the precision, meaning you get the similar result every time you measure it, if you measure it 10 times in the person on the same day. And bias, so you may get the same results, but they may be all too high or too low. We have to evaluate those things to create, to make sure we have an accurate measure. And having the most accurate measure that we can use readily is very important. And then how does it affect people's decision making. For instance, if removal of the race modifier impacts the ability for people to donate a kidney, we need to understand that, especially if the GFR is lowered by a change, then we have less potential Black people, that really affecting Black people in the setting of the race modifier that could be available for donation. And then, of course, for kidney screening, we want to get this right, and for our future management. And we don't want the situation where race, without the race modifier, that there may be more risk that is that it conveys than there actually is. And then, of course, medications, to have a certainty around dosing of medications. Other considerations was how would this impact previous clinical trials? We have these results based on these measurements are used, and we found that there was minimal or unclear impact on that. And how is it going to impact population tracking? We rely on the existing test strategies. Changing a test strategy was going to definitely create some confusion. And what was the impact on patients? With the testimonials we had, these were some clear themes that came out, that obviously we wanted to be patient-centered and we wanted the patient voice to be heard regarding this issue. Key thing that was brought up is that patients wanted early detection. They also wanted transparent communication about their health and their kidney health, about the imprecision of eGFR, about the trajectory of kidney function. The patients want timely referral to transplant and wanted a comprehensive evaluation. And I think that's all things we as physicians would like to make sure we reach that goal for patients. So the recommendations from the task force, which were published earlier, late in 2021, was that there was an equation developed that included all people but removed the race modifier. This equation, the CKD epi creatinine refit equation of 2021, was thought to be the best because it was developed without using a race modifier. It could be implemented immediately in all US labs. It does not include race in the calculation or reporting. It was developed in a diverse population. It is available with acceptable performance, and very importantly, does not disproportionately affect any one racial group by means of its use. The second task force recommendation is that we move cystatin C to the forefront of healthcare. That this biomarker has never required a race modifier to make it perform well. But we don't have much information confirming its use for decision making, and we need that for research, and we need to further evaluate its performance and use. There are two equations that use cystatin C. There's one that has the cystatin C alone and the creatinine along with cystatin C. One thing we realize is the more biomarkers you have to create an estimate of GFR, the more accurate it becomes. And so eventually we'd like to see this as first line when it's readily available, but for now it could be used as a way to confirm the GFR accuracy if needed by physicians. Thirdly, we felt that there is an opportunity here to increase research on using biomarkers for the best estimation of kidney function, and markers that are not influenced by social demographics, geographic, or genetic factors. We also noted that there could be increased research on racial and ethnic disparities in kidney disease, and wanted to make sure that was clear to the NIH and other research organizations that this is an opportunity to increase our knowledge about health disparities. And there needs to be increasing research about whether you account for body weight or index by body weight for drug dosing. We need more information on that to be really better at deciding or predicting what medications or how to dose medications in people. Confirmation is thought to be important here when you're not sure, or with that range in GFR crosses a threshold that would change your decision-making ability. We advocated for the use of either using the exogenous agents, which we know are accurate, as an alternative, or using one of the cystatin Cs to help. And we also want to make clear, which is consistent with guidelines from KDIGO and others, is that it's not just about the GFR measurement, it's also about assessment of albuminuria or proteinuria, which is so important in the progression of kidney disease. And we wanted to make sure that even though we're focused on GFR, that we made that point clear that a comprehensive assessment of kidney health is important. So implementation of the new eGFR is now what's been the focus. National Kidney Foundation has taken the lead on doing that. Patient education and professional education are there. I just put this out there to let people know that you can get your eGFR using the new equation by going to kidney.org and the GFR calculator. And if you have your cystatin C, you could put that in there too and get all the different measurements readily available to you. Most institutions are flipping to have or are working on flipping to the new 2021 refit equation, so you only see one GFR listed in the reporting. I want to make it clear, though, that as I mentioned in the early part of this talk, eGFR is important to get eGFR measurement to be exact as it can be, or as precise as it can be in everyone, and equally so. However, it is a small piece within the healthcare system for addressing health disparities in kidney disease. As I mentioned before, it is a complex interaction of multiple things that are inclusive of social determinants of health that lead to kidney health disparities, and they all need to be considered. So changing this eGFR equation is not a panacea. It doesn't fix the problem by any means. It's one of the things that can get us closer to really exploring people's kidney health in a comprehensive way, in a total way. And this just reinforces that all of clinical care, if we were to make clinical care perfect, we still wouldn't be addressing all the drivers of health disparities. That at least 50% of those drivers have to do with the physical, social, economic environment of people, and that this really is a healthcare policy agenda that needs to be at the forefront, along with healthcare in addressing health disparities and leading to health equity. And I love this chronic care model because it shows that we need communities involved, as well as the health care system and institutions involved in activating patients, informing patients so they get into self-care and helping to promote the best health for all people. This goes without saying with chronic kidney disease, as well as many, many diseases. And I'd like to see us reach for the perfect chronic care model in kidney health, and especially with regard to reaching kidney health equity. So I am, this is the end of my talk. I'd like to acknowledge the organizations that were so helpful in getting to the bottom of what was a year-long with almost 100 experts we listened to from 7 countries to come to the GFR task force final recommendations. And it was all done virtually because of COVID, which is actually quite amazing. We had a lot of support from the National Institute of Health, NIDDK, and I'm thankful for the students and trainees, patients who were involved. And here at the Cleveland Clinic, many of the studies that were used to come to this conclusion were, Cleveland Clinic was a major contributor to those. So I'm thankful for being here and being able to have a contribution and to lean on the contributions of others in this. So I am done and I'm happy to take questions. I'm going to stop sharing.
Dr. Gadegbeku, thank you so much for this insightful session and for the groundbreaking work that you're doing. For those who are attending this session, if you have any questions, please place them in the chat and I'll be happy to relay them. And I'll start with a question of my own. Doctor, you mentioned that race is an imprecise measurement of genetic ancestry. There has been so much conversation around APOL1 and FSGS. How should we interpret this, knowing that race is not a precise genetic measurement?
So APOL1 is a renal mutation, is a risk gene mutation that is associated with kidney disease. We yet have to learn how we use the risk of the 2 gene allele in predicting or preventing kidney disease. That's a huge gap in our knowledge. The key thing is that the APOL1 gene risk mutation seems to be exclusively in Black people. And so it is definitely part of the story, but there are many, many people, 85% of Americans who don't have renal risk factors, and these other social determinants of health are playing a role. Now, is it that some of the social determinants of health plus the risk factor are making patients more susceptible? That's highly likely. We need to further understand that, but it's more than that. It's more than that. And in terms of GFR, that's kind of a separate issue. And the issue was based on this observation of difference in creatinine at the same GFR in Black people. And that's something that we don't fully understand and need to be very careful about assigning based on what we know is a genetic, tapestry that we're made of, assigning someone to a certain GFR based on race when we know that's not totally a genetic thing, it's a social construct. So they're really separate, but the way they kind of come together is because we do have disparities and we do have this race modified equation that we've been using, and we do have the renal risks. And so we need to come together with more research to fully understand and embrace how these things are influencing health disparities, how this influencing care, how it's influencing management, and how can we best treat people of all races with this information. It really, it's another plug for precision medicine too, and precision kidney medicine. Whereas if we understand the defects for all these different diseases, not only APOL1, how we can target medicines to best and more effectively treat everyone.
Thank you for that answer. I think it really reiterates to me that every patient is unique and we do need precision medicine, but also that this is a very complex topic that is very multifactorial. So thank you for that. I do have one other question from the chat. It says, in the patient testimonials, it was expressed that patients are wanting comprehensive evaluation. Can you tell us what that looks like?
Wow, I think, well, for me as a physician, comprehensive evaluation would mean first, timely evaluation, that patients are seen at the appropriate time and screened at the appropriate time. And that would mean evaluating kidney health, which includes measurement of creatinine and assessment of GFR appropriately, as well as urine protein, and doing that under the context of, do you have diabetes? Do you have hypertension? What are your risk factors for kidney disease? So making sure that everyone is screened appropriately. And then once detection of kidney disease is there, to make sure that a nephrologist works hand in hand with primary care physicians to do the appropriate next steps, whether it's something urgent like a biopsy is needed versus we need to work on medical therapies that we have available. Now we're in a boom of new therapies coming out for kidney disease. It's so exciting now with the SGLT2 inhibitors, et cetera. But those things will not be helpful if they don't get in the mouths of patients. So it's about being able to fully assess a patient, meet them where they are in terms of how to best treat the blood pressure, how to best have patients self-monitor with their own blood pressure measurements at home. That to me is comprehensive care, where you come to an agreement together and you make decisions share in a shared way, and that I try to convey everything I know to patients in a way that they can understand, so that we can own this disease together. And I think that's what it means, but I really think the best way to know is really ask patients. And I don't think we've necessarily done the best in asking patients what they want and what they would need, and how can we best work with them along their journey of kidney disease, in which it's not a static thing, it's not a snapshot, it's actually a journey in which different things are important at different times. And I think I could be most effective in understanding where you are as a patient at the time I see you, and how can I work along with you. So that to me is comprehensive. It's not a one-time thing. It's a constant work, from screening to detection to management to transplantation. We have to engage in a way that we're being comprehensive with each other.